Hey everyone, Jonathan Brandt, Go Out Living. We have a special guest today. We have David Jeter, who is a physical therapist out in Spokane, Washington. How are you doing, Dave?
I'm great. Thanks for having me.
It's great to have you. Um, so you wanted to really get into almost misconceptions of physical therapy, if not, you know, kind of a different way that you go about it.
Yeah, I think one of the reasons why I go on podcasts like yours is because physical therapists are absolutely terrible at talking about what we do and why we do it. And so it is up to us as physical therapists to get out and say this is what we do and this is why we do it and this is how it can be beneficial for people who want to have better musculoskeletal health.
Yeah, it seems like it's mostly okay, you just went through surgery and hey, go get PT so you basically get back to your life.
Yeah, and that is definitely a misconception that I try to fight, and we can talk a lot about the other pieces of it. I mean, sometimes I like to start with when someone has something like low back pain, they go to their primary care physician. They say, I have low back pain, and their primary care physician has a thousand things that they need to look at, right? They're making sure that it doesn't look like cancer. They're making sure that it doesn't look like a kidney infection. They're making sure that it doesn't look like, some sort of infection or weird, terrible thing that's going on. Once we've decided that it is a musculoskeletal problem in terms of musculoskeletal pain, then then we need to start talking about how do we figure out not only what the tissue that is painful, define that tissue, but also look at the rest of the system above and below that tissue to decide what is not moving or is stabilizing well that is creating more stress on that tissue. And that's, in my view, where most of the medical community kind of falls down, right? They're pretty good at finding the painful structure, i.e., degenerative disc disease at L4-5, but they're not very good at saying why is that happening or what are the contributing factors that is creating a scenario in which L4-5 has more stress on it.
The
And that's
root
where
cause.
physical therapy really should be a driving force in improving how the body is actually working such that we can take stress off of that structure and make the whole system work more efficiently and thus decrease pain in that realm and improve musculoskeletal health, right? Which isn't just pain. It isn't just about pain. It's about movement. It's about strength. It's about balance. It's about endurance, that sort of thing. So if we just focus on pain, then a lot of people are pain free but have terrible musculoskeletal health. And there's lots of people who have pain but have pretty decent musculoskeletal health. It's just not a very good measure of whether you're healthy or not.
Right, and just because you don't have pain at the moment doesn't mean you're not going to if you're doing it wrong.
Yeah, I always think of that movie Wall-E, where everybody's sitting on the spaceship and they're in their recliners drinking the smoothies and they're doing absolutely nothing and they're so weak that they can't even stand up, but yet they're just happy as clams, right? Sitting in those recliners. That's not good musculoskeletal health,
Right.
obviously. And I know it's a
Right.
cartoon, but it's a sort of an interesting depiction of a lot of our society in wanting to be pain free, but sort of neglecting a lot of the other aspects of what is musculoskeletal health.
Well, we don't do anything until it's too late.
Yeah, yes, I think that's true, but also, I also think about it from an evolutionary standpoint. I mean, if the human body has been evolving over the past 1.5 years, up until very recently, our lifespan was about, I don't know, 35 years, something like that, and so you don't really have to worry about a lot of the medical issues if you die at 35, right?
Right,
and
exactly.
uh, and if you're a hunter and a gatherer walking and moving all day long, then your musculoskeletal health is probably pretty good. But then we invented the chair and we invented a whole host of other medical things that kept us living much, much longer. And now we find that certain parts of our body are breaking down because we're not moving the way we used to, and maybe we're not fueling ourselves in the correct ways.
can you, from a preventative standpoint, well, I guess, do you help people before things happen? I guess is a good way to ask that. I mean, do you happen to get people going, "Okay, this is a little off,"
Yeah.
you know?
Yeah, I don't really. I mean, in a perfect world, right? People would come to their physical therapist on an annual basis and say, "This is the exercise program that I'm doing. What can I tweak? What should I be doing? What should I be emphasizing?" And we could do that in a very short period of time, and kind of kick people back to their independent program. I tend to find people come in because they have an ache or pain because they strain something, whatnot. But in my say 60-year-old population and above, obviously the goal is to get the person moving well, get the person strong, get the person pain free, get their function up. But then I like to try to go to the next step and start talking to them about what does this look like long term. How can you keep your body moving well? How can you keep your body strong? How can you improve your balance? How can you improve your endurance such that you don't have these big declines that everyone is going to see in the later quarter of their life? And to me, there is no magic bullet for this perfect musculoskeletal health, but clearly that those four aspects are what I really try to emphasize with people. Once we've kind of gotten over the hump of, okay, this is a really painful structure. Okay, once that's calmed down and once we've gotten that going, now we start talking about how do we get you on a program that you can do independently so that I don't have to see you ever again, and maybe we can just wave at each other at Costco or something like that.
And that's where it kind of falls short. There, what I've seen, you treat, okay, knee replacement. You're doing a knee real quick as, you do your 6 weeks, whatever it is, and then you're out the door and there's no follow up. There's no, "Hey, let's keep this up," kind of thing.
Well, hopefully, we would see people prior to their total knee, right? Someone
Right.
has a painful knee, and their doctor should send them to physical therapy, or they should ask to go to physical therapy prior to that total knee, even if they need a total knee, right? That's I'm not saying that surgery is never a good and valid option for people. But if you have a low back and a hip and a pelvis and a knee and an ankle that aren't moving well, once you've had that total knee, you still have all of those things that aren't moving well. So if we can get some of those things moving prior to surgery, you become a much better surgical candidate, and you do much better on the back end of that post surgical rehab. So yes, we do a lot of post-surgical rehab, but I really like to see people prior to surgery and see what we can improve in terms of the system to see, honestly, whether things calm down on their own. You would be surprised. Lots of people come in with a rotator cuff tear and they think for sure I'm going to need a surgeon to tie that rotator cuff back down to my humerus. Well, the reality of the situation is that rotator cuff was torn because the system wasn't moving right and wasn't loading correctly. And if all you do is go in there surgically and reattach that tendon to the bone, and you haven't resolved the reason why it happened in the first place, there's no reason for it to not come back and not become problematic yet again. So, if I get to see that person pre-surgically, we get the neck and the upper back and the shoulder blade and the collarbone all moving properly, and we strengthen the whole system and improve the loading tolerance of the whole system. Hopefully they feel good enough that they feel like they don't need the surgery, even though that rotator cuff is torn. But if it's still problematic, then they become this much better surgical candidate so that the postoperative care is much easier.
Yeah, recovery is quicker.
Yeah.
Nice. Do you find that doctors are kind of coming on board with that? But
um, yes and no. Again, I have a lot of empathy for my colleagues in the primary care physician world, right? Because they are doing some really really important work to keep people alive and healthy from an overall standpoint, right? They're looking at diabetes, they're looking at high blood pressure, they're looking at cancer screening, they're looking at all the multitude of things that can go wrong in the body. And so the fact that when a musculoskeletal, I mean, no one's ever died of rotator cuff pathology, right?
Right.
No one has ever died of tendonitis. So when they see that kind of stuff, I can appreciate that it kind of gets swept like, okay, go elsewhere, go somewhere else. And I would like to believe that more and more physicians are sending people to physical therapy first, and then going to the surgeon. And frankly, the surgeons should want that as well, because they know the number of times that I've sent someone to a surgeon saying, hey, you know what, this is something that isn't going to be resolved fully with physical therapy. I think you're going to need to talk to a surgeon. The number of times that a surgeon doesn't do surgery on that person is very, very low. Right. But the number of times where surgeons complain about having this massive group of people who aren't surgical candidates come into their office, and they have to kind of triage it out and whatnot. I mean, surgeons want to do surgery, and that's fine. That's what they do. That's their hammer. They're looking for a nail. But and if they could get more people who were actually ready for surgery in their office, I think everybody would benefit from it.
Yeah, I agree. I mean, this brings up my wife, for instance. I kind of brought it up with you before. She ended up with neuropathy from a side effect of the chemo.
Mm-hmm.
And the frustration that I had wasn't okay, the side effect was mentioned beforehand.
Mm-hmm.
Once she got it, there was no PT available. They weren't
Mm-hmm.
even going to go that direction. And she struggled with walking all of a sudden. And it wasn't just, okay, it just doesn't feel right. It was, I'm falling down on the job situation. In that situation, again, I wish they would have been a little bit more on the preventative side and got her into somebody like you to say, okay, let's make sure we have enough strength in this leg that we know you're going to get this, or have a good idea you will, so we can be ahead of it, so we don't have to relearn things at the back end of it.
Yeah.
And I know
Um,
that's hard, but
yeah, I don't know. I mean, obviously, peripheral neuropathy is a really challenging scenario in that we don't really have a lot of curative treatments for that. But like you're saying, if the person can get moving a little bit better, if we can improve their balance, and if we can get them going on a cardiovascular program to improve blood flow and that sort of thing, we a lot of times can see some headway, or at least some compensation in terms of those balance difficulties. Um, but there's a lot of I see, especially in the peripheral neuropathy realm, I see a lot of snake oil kind of stuff out there with lasers and all kinds of things that don't actually move the needle. And I can appreciate why maybe physicians and oncologists say, well, you have peripheral neuropathy, and that's that.
and that's basically what it was. And to her, though, it was a simple brace that she found, and it was a little bit unusual, the way it picks up, because she also had drop foot. But
Okay.
it was finally one doctor said, "Hey, try this," and
Hmm.
it made all the difference. Other than she had lost all that strength in that leg leading up to that, and it was like just that one extra step that doctor took to say, this is what you need. This can help with this. I mean, was amazing to me. And it kind of goes back to you talking about empathy and just talking to your patient as well. I don't know if we do enough of that.
Yeah. I like I so one of my challenges as well is, again, a lot of practitioners are very busy these days, right? So if someone comes in again with knee pain or shoulder pain or whatever, there's not a lot of physical exam that's going on. It is a lot of, well, let's take an image of it and see, quote unquote, what's going on. And if I promise you, if you take an X-ray of my low back or your low back, we have degenerative disc disease, right? We have some degenerative changes because we're not 20 years old, or you don't appear to be 20 years old.
I'm 50, so yeah.
Yeah, so we have, by definition, we have degenerative changes in our back. My back feels fine right now, and I imagine if yours, whether yours does or not. But my point is seeing those kinds of changes on an image does not necessarily tell the story. And if we do a physical exam, we can more accurately pinpoint the painful structure. But then again, that physical exam also has to go a step further and say, what is and what is not working in the body such that there is more stress on this structure, and that's really getting lost. The the insurance companies these days are asking or forcing uh, patients and physicians to do 6 visits of physical therapy before they will allow an MRI to occur or take place, or they will authorize an MRI. And so this creates this weird and challenging scenario in which I get people in my office all the time who say, I'm just here for my 6 visits. I need an MRI to see what's going on, and I just need you to sign off on this so that I can get my MRI and get to the next step. And it's like, well, you know, and I can appreciate the frustration of the physician saying, well, the insurance company is dictating how I'm doing medicine. But in this particular case, while I loathe to defend insurance companies, it's probably the right answer to go to physical therapy prior to getting that MRI. Because first of all, most of the time I can tell you what structure is problematic by doing a good history, by doing a good physical exam. And then we can also maybe resolve that whole problem with improvements in how the body is moving and working and efficiently loading. And you may not need any other care than physical therapy. And honestly, that's obviously our goal, right? Is for the person to leave our office pain free, moving well, strong, able to do the function that they want to do. There's no reason to have an MRI if you have no pain and good function and good strength, regardless of what that MRI shows. Because what are you going to do with that information? Some people say like, "Oh, I just want to, I'm going to get that MRI anyway, because I want to get the information." It's like, well, what is that information going to do to drive your care in the right direction?
If you even need it at that point. If they
Yes,
took
absolutely.
advantage of you, I mean, like you said, they may not even need it.
Yeah, yeah. And it just seems like there's a lot of red herrings that come up where something shows up on an image, but then when you do a physical exam on that person, that structure is not actually problematic. And you can see that with different tests by doing different range of motions and strength testing, all the other physical exam things that we do. If you can't, if you can't reproduce the person's pain with a test that loads the structure that the MRI is showing, then the MRI, in my view, is not a valuable and important piece of the puzzle.
Do you think people in general aren't taking advantage of PT at this point? Do you think they're just
I
kinda checking the box and
Yeah,
move on, and then a year down the line going, "My knee still hurts."
we get. I would say less than half of the people who get referred to our office actually make an appointment. We get hundreds and hundreds of faxes from different physicians' office into our office, and the number of people who actually schedule an initial evaluation is probably less than half. So I don't know whether the other half it resolved on their own. I don't know whether the other half they decided to do some other treatment, massage therapy, chiropractic, whatever they decided to do, or acupuncture, or I don't know. But that's always a really big challenge for me to understand why you have this complaint of this problem. The physician has said, or practitioner has said, go to physical therapy to resolve this problem, or at least to start the process of resolving this problem, and then they choose not to. And I will say that physical therapy is not, or should not be, a passive modality, right? It is not. It should not be something where you are lying down and someone is doing something to you. Now, granted, there are parts of physical therapy that have that, but almost every single person who walks in my door will get some sort of exercise, right? And granted, there are a very small number of people who don't on day one for a variety of reasons, but for the most part, getting the body moving involves me moving somebody in a manual therapy sort of fashion. and then them doing some mobility exercises to keep whatever we got moving for better and more efficiently. And then as things move better, they calm down, and as they calm down, we start the loading process, where we start to get the body to be able to tolerate loads in all three planes and in function. And that's how you get actual better musculoskeletal health, right? That combination of mobility, dynamic stability, balance, endurance.
Because everything works together.
Yes, everything, absolutely, everything works together. So the example I have on that is patellofemoral pain. You have all of these young people. This is very, very common in the ages of, say, 12 to 18, where their bodies are growing and they're changing and whatnot. And they'll come in because they're playing some sports and they're having this anterior knee pain, the patellofemoral pain. And it is universally, it's almost always, I would say, I mean, I hate to say the word always, but let's just say almost always, it has to do with how the back and the pelvis and the hip and the knee are interacting in a way where, the knee only does one thing: it only bends and it only straightens. But the hip and the pelvis and the back need to be able to tolerate that side to side and rotational movements. And if you're doing high load activities like sports, then you have to have a back and a hip and a pelvis that are being able to move and tolerate load in those more strenuous directions.
Looking at the older generation with the degeneration, as well as, let's say, obesity, because we know we have an issue at this point. Does that complicate what you're doing when you're adding, okay, now you got a little extra weight that we're having to, deal with? Does that really have a huge impact on that structure?
Well, I'm gonna answer that in two ways. First of all, I think the weight thing is overblown for the most part. I think when someone comes in and they are, 50 pounds overweight and they have low back pain, it is very easy for a practitioner to say, hey, you're 50 pounds overweight. That's why your back hurts. And if you lost 50 pounds, then your back wouldn't hurt. And knowing that the person isn't going to go home and lose 50 pounds and come back to their office 6 months later and say, okay, I lost the 50 pounds, but my back still hurts. Right. So that's that. Weight can be a factor if you have something, again, unusual, like a thyroid problem, and you have this weird thyroid problem. You gain 50 pounds over a 2 or 3 month period. All of a sudden, you have all of this extra load on the system. I find I've had very obese patients that if I got them moving and I got them strong, they felt better. Now, should they lose a lot of weight because they're morbidly obese? Absolutely. And they should do that both for their musculoskeletal health and for all the other reasons that they would, from diabetes and cardiovascular health and all the other things. But I just think that the weight thing is definitely thrown out there a little too often as an excuse for why the person is, the way they are. So that's number one. In terms of degeneration, I find it really interesting. Sometimes it's interesting to look at what people can get away with in terms of when you see that 90-year-old person in your office and they have knee pain, but none of the rest of their body hurts. And then when you start looking at how they're moving and how their joints are working, you notice that definitely the rest of their joints don't look fantastic if you took a picture of them. And so the degeneration of that joint, I would say, is way too often correlated with that pain, right? People are making that correlation, and I don't know that it's as much causal as it is just correlated, right? So you can have lots of degeneration without pain, but I think people have a painful joint, they take a picture of it, they see degeneration, they say, aha, we have the thing that is the thing. And it's like, well, they've had degeneration for 2 or 3 decades in that joint. Why now?
Had nerves somehow, right? I mean,
Well, I guess what I would probably say is that they overloaded it by doing
something that
some kind of different function, right? Again, I keep going back to this knee pain problem, but it's just kind of a simple thing. If the hip doesn't rotate very well and it puts a rotational stress through the knee, then that knee will become painful. And some of the soft tissues don't like to be rotated when they don't do that motion. And so, yes, you have degenerative changes in that joint, and yes, it could be fired up from this rotational move. And again, I'm not saying that it couldn't be benefit from a total knee, but at the same time, it ain't necessarily so, I guess is what I'm saying, right? And I've even had people who have been sent pre-surgically for a total knee. We got their knee moving, we got their hip moving, we got their back moving. This person that I'm thinking of, this is always just like such a cautionary tale. He left my office being able to do a full squat, being able to walk up and down stairs, being able to walk for an hour without pain. Described no pain at all. He left my office on that day, and the next day he was in the surgeon's office, waiting, getting ready for his total knee. And he had his total knee, and when he came back, he was very happy with his therapy. He came back post surgically, and we worked on it and tried to get him moving and whatnot. And he was never pain free again.
but we seem to jump towards surgery. We seem to jump towards, well, our Western medicine as the answer to anything and everything.
Well, I'm a big fan of that movie, or not movie, the TV show Mad Men. And in Mad Men, there's a scene where John Hamm is talking about how everyone wants a spaceship. They want a piece of technology that's going to fix all of their problems. But what they really need is a time machine, something that will take them back in time to a time when they could move better. Or I say move better, but he was talking about it in a different context. But yeah, everybody's looking for a spaceship, right? Everybody's looking for a pillow that will fix their neck, or a device that will do a certain, keep their posture up or whatever. It doesn't mean that you can't have an AFO that helps lift that person's foot up if they have foot drop, and that can't be beneficial, right? There is technology that can, using a cane, using a walker. I mean, there's all kinds of technology that can be beneficial, but to me, improving how the body actually works first and doing as much as you can in that realm is where you start. And then you start thinking about, okay, what other technology can we add to this situation that can improve this situation?
And it's not going to hurt you in the end.
Exactly.
Yeah. A side effect. Okay. So that makes me think of people that run into and get injections.
Yeah. So I think I have a lot of feelings on injections. Um,
Good.
um, I think injections can be an incredibly valuable thing, right? Because if I'm trying to get someone moving well and they just have this one joint that is very, very irritated, and I'm trying to move things above and below it, and but they just can't really tolerate much because of that painful joint. It's very nice to shoot a little cortisone in there. Again, presuming that they can do that medically, right? There's all kinds of reasons why you shouldn't have a cortisone injection medically. But if you can artificially calm that joint down, then maybe you can tolerate more of getting the rest of your body moving. Where I have a problem is that I typically find people who have a story that sounds like this. I had a cortisone injection in my shoulder and it felt awesome. It was great for 6 months. And then I had another one and it worked for 3 months. And then I had another one and it worked for a month. And my last one only worked for a week. And now I'm in PT because they said they couldn't do anything for me. And I thought to myself, well, that's because they haven't been trying to fix the problem. They've just been trying to tell that painful structure to shut up and stop complaining and to be quiet, rather than say what is going on in this neighborhood that is creating more stress on that structure. So cortisone injections can be incredibly valuable for also diagnostically, right? If you think that you have a problem at L4-5 and in your facet, if you shoot cortisone in there and it doesn't change anything, boy howdy, I don't have a great expectation that doing some sort of surgical intervention at that level is going to make much of a difference. But if you, again, similarly, if you have a hip labrum that is quite irritated, and you do an intra-articular injection and it calms it down quite nicely for a period of time, and you're doing all the things you can do in terms of getting the rest of the lower quarter moving and loading properly, but then it comes back, then that gives the surgeons a really nice indication that by doing something to that structure, we can improve the situation. So cortisone injections are not necessarily bad. They're not necessarily good. And again, there's a there's the side effect that's separate and apart from the side effect argument. I'm just saying that people, I think of them as a fire extinguisher that puts something out. But if you don't look and see why that fire started in the first place, then that fire extinguisher is kind of worthless.
I keep going back to when I was a surge tech and we did back surgeries, and
Yeah.
it was almost, you knew the path this person was going to be on. It was going to start with one level,
Hmm.
then they're going to start having pain, and then it's going to be in the injections, possibly a pain pump. It was a little bit different for everybody, but it always led back to, okay, more surgery. It happened to every single one that I saw. Are they even attempting PT at that point, or even in the beginning?
Again, different surgeons have different ideas about what the process should look like. Again, there what I take from it is that surgeons are looking at that painful structure. They're looking at that segment that has a spondylolisthesis or is really broken down and it looks terrible. It's pinching the nerve, all of those things, and they say, "Wait, man, we got to do something to this level to make sure that this nerve doesn't get any more compressed than it is," which is a valid thing to be thinking about and trying to do. But the question that I find they aren't asking even themselves is, why did this start in the first place? What is going on in the structures above and below this one segment that are creating so much stress on this segment that it's breaking down? And to me, that fundamental question is what we are really trying to answer at physical therapy, right? The classic is your hip doesn't extend, right? It doesn't go behind you, right? So if I'm walking and I take a step forward with my right leg, my left leg has to go behind me, right? The whole leg has to go behind me with hip extension. If my leg doesn't go behind me because my hip just doesn't move that way, then I have to compensate for that. And a lot of times that is bending forward so that now, because I'm a little bit bent forward, my hip never has to go behind me. Well, if I live in a 20-degree flexed posture, that puts a tremendous amount of stress on the lumbar spine, and that it breaks down. Now, is that the lumbar spine's fault? No, it is the fact that that hip doesn't move the way that it's supposed to, and is creating the scenario in which the person has to compensate by doing that forward flex posture. So yes, you're not wrong that if someone goes in and has a surgical intervention and isn't doing physical therapy, again, I would say pre-surgically and post-surgically, without an emergent situation, right? If you have a cauda equina syndrome where the person's having incontinence and they have saddle paresthesia and all kinds of things where it's a dangerous situation, obviously you go in there and you do the surgical intervention that you have to do on an emergency basis, right? Emergency surgery is emergency surgery in whatever part of the body that it is, but post hoc, you better be figuring out some of the things that led up to that situation and try to resolve those things, and so that the person can, again, I come back to, improve their musculoskeletal health so that they are spreading out the stress of the load of gravity and ground reaction forces and other loads efficiently and effectively. And again, that's at the end of the day, being able to move, being strong, having good balance, and having good endurance is musculoskeletal health. And the more you have of that, the better you're going to do, for the most part. But car accidents happen. Slipping on the ice in the Walmart parking lot is going to happen. You're going to break a humerus that way. Falling off a ladder. I mean, there are things that are going to happen, where, I mean, you're not going to be you're not going to be pain free all the time because you're alive, right? And, like when I tell people, like, you're not going to be 100% pain free 100% of the time because you're alive, and
Exactly.
sometimes
It's
I
a
say also life is pain, right?
it is. I just had to move a house. Well,
Yeah.
the stuff in the house, but yeah, trust me, painful. Okay, this is my last question, but it's not just towards PT. Um, Coming from being in the hospital, seeing my wife go through what she did, I find that a lot of care, well, there isn't a lot of care anymore. When I say that, there doesn't seem to be a lot of motivation to do somebody's job. And yeah, we can look at it from the PT standpoint where, I saw my wife needing to get up to move and nobody wanted to get her up and moving. It was, "Oh, how do you feel today?" And it's not just your industry, it's all of it. It's the young kids coming in. There's just not that motivation in themselves to do it. As the health industry itself, how can we be there for our patients? How can we do better for them?
Yeah. Um,
I know,
I don't
hard
know. I
question.
always, I certainly get my motivation from the people who tell me that their life has been changed. Where the person who can't play with their grandkids, or they can't go to the soccer game because they can't walk across the 300 or 400 yards across the field, so they can't watch their kids' soccer game. And because they got moving and because they feel better, they can now do the thing that they want to do, and that really changes their whole outlook on their life. And especially if I can get that person motivated to take it a step further and become independent with how they keep themselves healthy from a musculoskeletal standpoint. That's my motivation, because when I can actually change somebody's life, which doesn't happen as often as I would like it to, but it happens, right? It happens sometimes. That's the thing that really keeps me going. And I think that, maybe some of what you're sensing is, especially in the hospital setting, it's a lot of putting out fires and not a lot of success stories, and just a lot of trying to keep their heads above water, and trying to do what they can for patient with the resources that they have. And I imagine burnout is a big piece of that. So yeah, I don't have a good answer for that, except for, for me, um, when that person actually changes direction in their life, that's a really big impactful thing for me.
I look at this podcast and it's just reaching one person. If we can do that, we're successful, is how I look at it. Um, Anything you want to say on the way out?
No, I appreciate you giving me the chance to chat with you a little bit about what physical therapy is and what we do, and why people should start with physical therapy if they have musculoskeletal pain, and then think about, once this pain has improved, how can I maintain and improve overall musculoskeletal health, such that you can stay living a life that is worth living.
Totally agree. David Jeter, physical therapy. Really a huge pleasure to have you here and give your point of view, which I think a lot of people need to take seriously
Well, I
because you
appreciate you
guys
having me.
do an amazing job and people need it, take advantage when you get it. All right, everybody. As we go out, everybody knows, find the attitude, keep the attitude, go out living. Bye.